Breast cancer is the most frequently diagnosed cancer in women, and it's the leading cause of death from cancer in women worldwide. But from the beginning, I really want to emphasize the importance of understanding that really breast cancer is very heterogeneous disease. It's composed of several biological subtypes that have a distinct behavior and response to therapy. So when we think about the breast cancer, when we talk about the treatment, diagnosis, prognosis of breast cancer, what matters is not just the size of the tumor or extent of the tumor. The biology of the tumor really matters. So when a woman is diagnosed with breast cancer, usually we start by detecting the cancer in the breast. From the breast, the cancer can move from the breast to the lymph nodes or can move through the blood to the other parts of the body. And then when we evaluate the extent of the disease, we do something called the staging. Staging means evaluating the size of the tumor in the breast, the extent of the tumor in the lymph nodes or through the body. And then based on the staging of breast cancer, we determine the treatment and prognosis. And the breast cancer can be stage 1, 2, 3, or 4. Stage 1 is usually smaller tumor in the breast, less than 2 centimeters in size. Stage 2 is a little bit bigger tumor. Stage 3 is the tumor that moved to the lymph nodes. And then the stage 4 is the tumor that started to spread through the blood to the other parts of the body. So stage 1, 2, and 3 breast cancer can be cured. We implement surgery plus minus radiation plus systemic therapy. And then the stage 4 can be treated. It's not curable, but it's treatable disease. Now, what matters too is not just the stage, not just the size and the extent, but the biology of a disease. So for every breast cancer, we detect the presence of the estrogen, progesterone, and HER2 proteins on the surface of the cell. And we detect the grade of the disease. And in the new staging classification, the grade, the presence of the estrogen, progesterone, and HER2 proteins actually became a part of the new staging for breast cancer. So what that means, the least invasive looking cancer under the microscope are the grade 1, the more invasive looking are grade 2, and the most invasive are grade 3. So this is something that usually pathologists tell us how the cancer look under the microscope. And then the presence of the hormone receptor and HER2 proteins actually matters, because if you think about the aggressiveness of the tumor, the most aggressive breast cancers are estrogen, progesterone, HER2 negative. They're called triple negative breast cancer. And then kind of in the middle are the ones that are HER2 amplified, and the least invasive breast cancers are estrogen positive and HER2 negative. So when we talk about the breast cancer, it's not just enough to say, the size of the tumor extent. You have to kind of know really the biology of the disease to evaluate, the prognosis, therapy, and the response to therapy. So the anti-estrogen therapy is therapy that is used just for patients who have estrogen receptor positive breast cancer. So patients that had a triple negative breast cancer that's estrogen negative, we do not use anti-estrogen therapy. But around 75 to 80% of patients that were diagnosed with invasive breast cancer will actually have hormone receptor positive breast cancer. And these are the patients where we would use anti-estrogen therapy. Now, the anti-estrogen therapy can be used as a therapy for this early stage breast cancer if we use these medications prior to surgery. And sometimes we do that with the goal of shrinking the tumors. That's called neoadjuvant treatment. If we use this medication after surgery, that's called adjuvant treatment. We can use the anti-estrogen therapy in patients who have metastatic hormone receptor positive breast cancer to control the disease. But we can use these pills for women who do not have breast cancer, but they are actually at the risk of developing breast cancer. So we can use them for prevention of breast cancer. And these are the patients who have the high risk for developing breast cancer based on maybe their positive family history or because they received radiation to the chest wall, or patients with something called ductal carcinoma in situ, that's called stage 0 breast cancer. So I'll kind of go through my talk. I'll kind of touch base on all of these three elements where we can actually use these medications. Now, these are the anti-estrogen pills that we have available. We can divide them in three big groups. Selective estrogen receptor modulators, that's tamoxifen and raloxifene. Tamoxifen is the first anti-estrogen medicine that we have been using since 1977. And we are still using this pill, and we are using this medicine for treatment and prevention of breast cancer. The raloxifene is the sister medicine to tamoxifen, but it's used just for prevention of breast cancer. Then we have three medications, anastrozole, letrozole, and exemestane. They're called aromatase inhibitors. We use them, again, just like tamoxifen, for early metastatic breast cancer and for prevention. And then we have the last two medicines, fulvestrant and elacestrant, and these are called selective estrogen receptor downregulators. We use these two medicines just in patients with metastatic breast cancer, that's estrogen receptor positive. So at the beginning, we will be focusing on anti-estrogen therapy in early stage invasive breast cancer. So as I mentioned, when I say early stage, so this is the breast cancer that's diagnosed as a stage 1, 2, or 3, that's curable. And the treatment for this type of breast cancer will be local therapy, which is surgery plus minus radiation. So surgery to remove the tumor, and radiation, in some cases, we use the radiation to kind of sterilize the field. And then systemic therapy, which is the therapy that goes into your blood. That's the chemotherapy, anti-HER2 therapy, and anti-hormonal therapy. So we would use this anti-hormonal therapy in patients who have estrogen receptor positive breast cancer. And this is around like 75 to 80% of patients. So usually when I see someone who have estrogen receptor breast cancer, the first question is that, if I have estrogen receptor breast cancer, does it mean I have too much estrogen in my body? And the answer is no. The estrogen receptor positive breast cancer just means that the estrogen that's in our bodies can actually go through these estrogen receptors and feed cancer cells. So estrogen receptor positive breast cancer means it's a cancer that's feeding off estrogen. The estrogen is in our blood. For premenopausal women, the source of estrogen are ovaries. For postmenopausal women, the ovaries are not working, but we still have estrogen. The estrogen is coming from adrenal gland, which is the little gland that's at the top of our kidneys, and it's coming from the fatty tissue. So you'll see that, we encourage oral patients to lose weight, don't gain weight, because as we are postmenopausal, the fatty tissue is becoming source of estrogen. So basically, the estrogen that's in the blood can actually go through our body. And for estrogen receptor breast cancer, there is a door. The estrogen can get into the cell, and it's feeding cancer cell. So there are 4 medications that we can use to fight this, and this is tamoxifen and anastrozole, letrozole, and exemestane. So they are anti-estrogen, which means estrogen is bad for you. There is estrogen receptor positive breast cancer, we fight estrogen. And we can use these, we can choose 4 different, we can choose one medicine out of these 4 different medications to fight estrogen. They have a different mechanism of action. So the tamoxifen is called selective estrogen receptor modulators. It inhibits the growth of breast cancer cells by basically blocking the estrogen receptor. And these aromatase inhibitors, they decrease the plasma estrogen levels by inhibiting the enzyme that is responsible for peripheral conversion of androgen to estrogen. So usually what I tell my patients, I say, think about the cancer cell as this room. So if the cancer cell is this room, the estrogen receptor would be a door. So when we look at your pathology report, they say that, the estrogen receptor positivity of the cancer is between 0 and 100%. If it's 0, means this cancer cell doesn't have a door. That's estrogen receptor negative breast cancer. We don't use anti-estrogen therapy. But if this cancer cell has 100% estrogen receptor positivity has 100 doors. That means that the estrogen that's in the hallway, that's in your blood, can go through all these doors and can feed the cancer cell. So if we use tamoxifen is a little soldier standing in front of the door. It basically said, hey, it's okay, there's an estrogen in your body, I'm just blocking the door. So that's why we can use tamoxifen in pre- and postmenopausal patients. But these aromatase inhibitors, they are the medications that they actually block the production of estrogen. So they decrease the level of estrogen in the hallway. So they work just for postmenopausal patients. So both of them have anti-estrogenic effect, but they have a little bit different mechanism of action. So the tamoxifen is called selective modulator, because the way this works, it actually blocks the doors in the cancer cell in the breast, but can actually enhance the doors or increase the estrogen receptors in the bones and in the lining of the uterus. So with the tamoxifen, we'll talk a little bit later about that, but there is potentially increased risk of uterine cancer, and the tamoxifen can cause building up the bones, the bone density. The way the tamoxifen works, once the pill is ingested, it goes into the liver, and in the liver, it's actually metabolized into the active form of the tamoxifen that then gets released into your body. So there are certain medications, for example, some of the antidepressant medicine that can block the enzymes in the liver, and they can decrease or affect the metabolism of tamoxifen. And when people are on tamoxifen, we usually advise to avoid grapefruit. That's one of these that's one of these kind of type of the food that can impact the enzymes in the liver. So these are kind of, these slides actually go over the side effects of tamoxifen. So the tamoxifen can slightly increase the risk of blood clots, deep venous thrombosis, and pulmonary embolism. So if the patient had a blood clot before, usually I avoid tamoxifen. Now, there is a slightly increased risk of uterine cancer. The chance of that is small, but if we have patients on tamoxifen who develop vaginal bleeding, let's say if it's premenopausal patient develops a vaginal bleeding in between periods, or postmenopausal patient who develop vaginal bleeding, we usually stop the tamoxifen and we send the patient to the gynae for evaluation. Tamoxifen is more likely to cause the thickening of the endometrial lining that can be associated with bleeding, but usually in these cases, women are having pelvic ultrasound to evaluate how thick the endometrial lining is, and in some cases, they need to have a biopsy of the endometrium. Now, the other side effects associated with the use of tamoxifen could be fatty liver, hot flashes, vaginal discharge, some sexual dysfunction. So this is the slide that goes over a little bit kind of these scary side effects, and it gives us a little bit kind of perspective in terms of the occurrence. So this was a toxicity of tamoxifen for patients who were at a high risk of developing breast cancer. Half of these women were on placebo pill, half of them were on tamoxifen. So if you look at the risk of blood clot, now they reported this as annual rate per 1,000 women. So if you are age less than 50, the risk of blood clot per 1,000 women is 0.13. But if you on tamoxifen, that goes to 0.25 per 1,000 women here. So that's low risk. If you look at the blood clot, like the deep venous thrombosis, if we look at the women age over 50, that's 0.89. So per 1,000 women of tamoxifen and 1.33 on tamoxifen. So the risk is still low. We look at the occurrence of the invasive endometrial cancer. You see that the risk in women aged less than 50, it wasn't such a high increase, goes from 0.8 to 1.1. But age over 50 goes from 0.5 to 3 women per 1,000 women annual rate if women are on tamoxifen. In addition to tamoxifen, there is 3 other medications that we can choose to treat breast cancer, early breast cancer, and they are called aromatase inhibitors. There is 3 of them: letrozole, anastrozole, and exemestane. Now, while tamoxifen can work for pre- and postmenopausal women, these aromatase inhibitors, they work just for postmenopausal patients. They work differently. As I mentioned, they work by basically inhibiting the enzyme that produces estrogen, and they have been used for chemo prevention, for preventing breast cancer. They are used for management of early stage invasive breast cancer, and they are used for management of metastatic estrogen receptor positive breast cancer. One of specific side effects of these medicines is that they can actually increase the chance of osteoporosis. So you have tamoxifen that builds up your bones, and then you have these medications that cause a little bit higher risk of bone loss. So when we have patients on the aromatase inhibitors, we do have to do a bone density scan at the baseline, and then we do this every 2 years. Patients with aromatase inhibitors, they could have a little bit of more joint stiffness and joint pain. So, and that's a tough one. So because I have patients who already have joint pain, so then they start this pill and they don't feel a difference. But then you do have patients who start the medicine and they say, and I hear this a lot, they say, I wake up in the morning and I feel stiff and I feel like I'm 80 years old, but things get better during the day. And that's usually this characteristic stiffness, joint stiffness from tamoxifen. From the aromatase inhibitors. And most of the time when we stop the medicine, that kind of goes away. Probably takes 3 to 4 weeks for the medicine to get out of your system. But if there is a joint stiffness, we talk about exercise. There was actually a study that showed that women who were exercising, I think 150 minutes a week, they had less problems with the joint stiffness. Then supplements like glucosamine chondroitin can help with joint stiffness. Acupuncture have been shown to be helpful. And then in some cases, we just change from one aromatase inhibitor to a different aromatase inhibitor. So for example, if we start people on letrozole, we can change to exemestane, or sometimes we change the medication to tamoxifen. Just in some cases, one medicine may be a little bit better tolerated than the other. And then the aromatase inhibitor, as well as tamoxifen, can cause vaginal dryness. We usually try to avoid vaginal estrogens, but we do talk to patients if we can, but we do talk to patients about long-acting vaginal moisturizer like Replens. Then these medications can cause loss of bone density. I mentioned, patients should be on a vitamin D. And then we do a bone density scans, DEXA scans every 2 years. And then the hot flashes. The hot flashes can occur with any of these anti-estrogen medication. Usually, if women had hot flashes when they were going through menopause, the hot flashes may occur again. If they didn't have any hot flashes during when they were just going naturally through menopause, they probably most of the time don't have them. But if there are hot flashes, we talk about starting patients with magnesium supplements. Magnesium glycinate, 400 milligram daily, have been shown to potentially help with hot flashes. We just have to be cautious. Magnesium can cause diarrhea. So if people are on magnesium and they develop diarrhea, they should stop the medicine. And then we use low-dose antidepressant medications. There is a medicine called Effexor or venlafaxine that has been actually studied in women who were on these anti-estrogen medication to help with hot flashes. This is the medicine that at the higher dose is used for the management of depression. We usually use it as a very low dose, 37.5 up to 75. And then there's another medicine that's actually approved for hot flashes. It's called Bristol. That's kind of a paroxetine at the very low dose. So these are usually the kind of the supplement for the medication that sometimes we have to talk to with our patients if they have symptoms. So if we compare tamoxifen to these aromatase inhibitors, aromatase inhibitors are associated with a higher risk of osteoporosis. There is a risk of cardiovascular disease and high cholesterol, but they're associated with a lower risk of blood clots, endometrial cancer, and fatty liver disease. In terms of the cholesterol changes, we do have kind of some data suggesting that these aromatase inhibitors can increase the risk or can increase the level of cholesterol. I think in study where they compared this to tamoxifen, there was like 8% chances of increasing cholesterol with the aromatase inhibitor versus 3% with tamoxifen, so it's still low. But we do recommend our patients who are on these anti-estrogen therapy to see their primary care doctor to have their cholesterol checked once or twice a year, just a regular checkup, and basically keep an eye on things. So this is just kind of the NCCN guidelines, kind of, just to have just a little presentation. What do we do when we see someone who was diagnosed with early breast cancer? So the first thing you have to determine is this patient premenopausal or postmenopausal? Because if the patient is premenopausal, we can offer tamoxifen, or in some cases, we can still do aromatase inhibitor, but we have to suppress their ovaries. And if the patients are postmenopausal, we usually start with aromatase inhibitors. So the definition of the menopause is really important. So when I see women in my clinic, the postmenopausal patients are the patients, for me, are women 6 years and older, considered a postmenopausal, or women less than 60 years, if they did not have their period for at least 12 months, or in patients who had both of their ovaries removed, they are postmenopausal. And then sometimes we have patients that are premenopausal at the time of diagnosis. We start them on tamoxifen, and then their periods stop. And usually in this case, we want them to be, no menstrual period for 12 months, and then we check the hormones, estradiol and FSH, to determine if they are postmenopausal. I usually receive a lot of questions about, do we check the hormones, estradiol and FSH on a regular basis when we start people on these anti-estrogen medication? Do we need to check the hormones? And the answer is no. If you are postmenopausal, your hormones are low, we don't have a tendency to check them. But this would be one case where I do check the hormones, and this is when, as I said, the women have been on tamoxifen and they didn't have a period for their 12 months. And then we really want to make sure that they are postmenopausal before we maybe consider switching to one of these aromatase inhibitors. Because if you assume that someone is postmenopausal and you put them on aromatase inhibitor and they are really not, these aromatase inhibitors are not going to protect them. So if we talk about the anti-estrogen therapy in postmenopausal women with this early breast cancer, the data, we can basically choose one of the four medicine. There's tamoxifen, and then there is 3 other medication, letrozole, anastrozole, and exemestane. But the studies do suggest that these, aromatase inhibitor work a little bit better than tamoxifen. So most of the time, we start patients on the aromatase inhibitor. Now, if there is a postmenopausal women who have osteoporosis, small tumors, and you worry about worsening osteoporosis with aromatase inhibitor, we would use the tamoxifen too. When we start the tamoxifen, there is usually a question, okay, how long should I be taking this medicine? So nowadays, for premenopausal women, we usually, recommend 10 years. But for postmenopausal patients, we recommend 5 to 10 years. So for patients who have smaller tumor, negative lymph nodes, usually we can consider stopping after 5 years. If the patient have a lymph node positive disease with bigger tumors, we can extend up to 10 years. Nowadays, there is a test that sometimes we use. It's called breast cancer index. It's a test that can be that sometimes can help us determine, is there a benefit of extending anti-estrogen therapy, beyond 5 years? And I think that these tests will become even more sophisticated in the future. So for our premenopausal women, we would use anti-estrogen therapy for 10 years. And for premenopausal patients, we start them on tamoxifen. Now, when women are on tamoxifen, they can still become pregnant. So this is really important. Women, premenopausal patients should not become pregnant on tamoxifen because tamoxifen is teratogenic and it's bad for the baby. So while on tamoxifen, the women have to use, effective means of contraception. And if they are planning pregnancy, we usually advise to be 2 to 3 months off tamoxifen if they are, planning or before they start, attempting to become pregnant. In addition to tamoxifen, for premenopausal patients, we can use these aromatase inhibitors, but we have to make them postmenopause. So we use ovarian suppression, which means we can suppress their ovaries, making them postmenopausal by giving them medicine. There is injections that we can give every 4 weeks, or removing the ovaries. And once we make them postmenopausal, then we can use these aromatase inhibitors. Now, usually this strategy of using ovarian suppression plus aromatase inhibitor is used for premenopausal patients who were diagnosed with a little bit more advanced breast cancer. They're at a higher risk of cancer spread, and these are usually women who do require chemotherapy, as well as the patients who are aged below 35. So I just put the next couple of slides because there is sometimes some additional pills that we use in addition to the anti-estrogen therapy in patients who have a high-risk breast cancer. And we call this targeted therapy. So there was a study that looked at women who were diagnosed with breast cancer, who had surgery. And then after surgery, they were found to have a pretty extensive disease. Or in some cases, even if they had extensive disease prior to surgery, they had to receive chemotherapy. But they had more than 4 positive nodes or 1 to 3 positive nodes with a bigger tumor, higher grade of tumor. So these women were actually participated in the study where half of them got they were treated with plus minus chemo, surgery, radiation, but half of them got anti-estrogen therapy alone, and half of them, in addition to the anti-estrogen therapy, received a pill that's called abemaciclib or Verzenio. And this is the pill that people take for up to 2 years. And the study showed that women who received anti-estrogen therapy and Verzenio, they have improvement in invasive disease-free survival compared to women who did not receive this medication. So basically nowadays, if I see a patient who was a patient is diagnosed with breast cancer, it's estrogen receptor positive, HER2 negative breast cancer. It was treated with curative intent, but bigger tumor, multiple positive nodes. In addition to the anti-estrogen therapy, usually up to 10 years, we talk to them about actually using one of these targeted medication, and Verzenio is one of them. The side effects from this medicine is diarrhea, so it's still there are still side effects associated with all of these pills. And then in addition to Verzenio, there's another pill that we can use, and this is called olaparib. This is actually for patients with BRCA positive mutations who have HER2 negative high risk early breast cancer, and we can use this pill for up to 1 year. So moving forward, we'll just change gears a little bit. So you'll see that I was talking about all these medications to treat breast cancer, to decrease the chance of cancer coming back in your body. But we actually can use anti-estrogen therapy for prevention of breast cancer. So we can use these pills for women who do not have a diagnosis of breast cancer, but they are actually at the higher risk of developing breast cancer. So most of these women we actually refer to our high-risk breast clinic. I did put a phone number at the end of the slide. This high-risk breast clinic is located at the Central DuPage Hospital and Delmer Hospital. And this is for patients who have multiple family members with breast or ovarian cancer. They have first-degree relative with breast and ovarian cancer, especially diagnosed at the early age, like age less than 50. If they had a breast biopsy and they were not diagnosed with breast cancer, but they were found to have some atypical cells, like a typical ductal hyperplasia or a typical lobular hyperplasia, a lobular carcinoma in situ, if they actually have a known genetic mutation that would increase the risk of developing breast cancer, or women who had, for example, lymphoma in the past that was treated, they got radiation to the chest wall, that actually increased the risk of developing breast cancer. So these women, I think it should be seen and referred to high-risk breast clinic. We have our educators there, they would kind of calculate their risk of developing breast cancer, and that would impact our recommendation of how to follow them in the future. So these are the women that in addition to having, mammogram once a year, may need to have an MRI to kind of increase the whole screening process. And then some of these patients get referred to medical oncologists to talk about preventing breast cancer. So these are women which know they were not diagnosed with breast cancer, but they are at the risk of developing breast cancer. As I mentioned, 80% of the breast cancers are estrogen receptor positive. So we basically talk to them about the same pills that I mentioned previously. We talk about tamoxifen, we talk about aromatase inhibitor, and then we talk about one more pill that's called raloxifene. And usually these pills people take for 5 years to prevent breast cancer. So the raloxifene is approved just for chemo prevention. It's a sister medicine to tamoxifen. It has a little less side effects than tamoxifen. And raloxifene or Avista is actually used for treatment of osteoporosis. So if we see patients who have osteoporosis, but they are at the higher risk of developing breast cancer, raloxifene may be a very good option for them. Now, for prevention, in addition of using tamoxifen at the regular dose, which is tamoxifen 20 milligram daily, this is a tamoxifen dose that we use for treatment of early invasive breast cancer or stage 4 breast cancer. There's a lower dose of tamoxifen. We call this baby tamoxifen. It's 5 milligram daily, and it has been studied for prevention. And the study was very encouraging, and we are using more and more this 5 milligram tamoxifen, especially for postmenopausal patients, just for prevention of breast cancer, not for treatment of invasive breast cancer. In addition to using this medicine for women who were never diagnosed with breast cancer, but they have, for example, positive family history, we can use an anti-estrogen therapy in preventing breast cancer in patients who were diagnosed with ductal carcinoma in situ. So the ductal carcinoma in situ, we call this stage 0 breast cancer. So what that means there is a cancer cell incorporated in the duct in the breast. And DCIS usually presents as kind of calcifications on the mammogram. Usually that's how this disease gets picked up. And then after the biopsy that showed DCIS, we do send patients to our surgeon for excision of the DCIS. And the goal of excision is to remove the cancer cell and to make sure that there's really no invasive cancer in addition to the DCIS. If there is no invasive cancer, then once DCIS is removed, we talk about the same medications that I mentioned. We talk about tamoxifen, we talk about potentially baby tamoxifen, we talk about these aromatase inhibitors. for prevention of new cancer. And these are the women that in addition to seeing the medical oncologist, we will probably end up seeing the radiation oncologist to talk to them about potentially radiation to the breast to prevent new breast cancer. But I think the important thing to distinguish, if there is invasive breast cancer in the body, the goal of that's estrogen receptor positive, the goal of these pills is to prevent this cancer from spreading. So what that specifically means, I have patients that sometimes they have their surgery, they saw the surgeon said, oh, you had this small cancer, it's removed from your body, but go and see this medical oncologist. So they come to see us and they're wondering why they're actually seeing us, because the cancer is removed. But the one thing that we have to understand is that the way the breast cancer can spread, it can start in your breast and it can go from the breast to the lymph nodes, or it can go from the breast to the blood to the other parts of the body. So if there is a cancer cell in the blood, and sometimes these cells are so tiny, we don't see them, we call them micrometastases. If they stay in the blood, they can spread to the liver, to the bone, to the other part of the body years later. So you have all these, we have all these friends, we have friends and neighbors, and they said, we have breast cancer, the cancer is removed, but the years later, the cancer is back, and it's the same breast cancer, but it's back in the bone or in the liver. And the only way that this cancer can be back is because there were little cells in the blood that surgery, didn't remove them, the radiation didn't affect them. And that's why we actually talk to patients about these pills, the anti-estrogen medication, because they are the one that are going to kill these little cells. So we put patients on the pills, anti-estrogen medicine for 5 to 10 years to kill any little micrometastatic disease. But when we have patients who were diagnosed with a DCIS or doesn't have a diagnosis of breast cancer, we use the same medicine, but to prevent a new breast cancer. And sometimes if you are talking to a patient about prevention, you focus a little bit more about the side effects of the medication because you don't want to hurt women. But if there is a diagnosis of invasive breast cancer, we always recommend, and it's estrogen receptor positive, we do recommend the anti-estrogen medication because we think that the benefit is higher than the risk associated with these pills. And then, finally, we do use the anti-estrogen therapy in people with metastatic estrogen receptor positive breast cancer. So the metastatic disease means that the cancer moved from the breast to the other parts of the body. So it can be found in the liver, in the bone, and it is estrogen positive breast cancer. So for these patients, usually as a first line of therapy, we don't use actually chemotherapy. We use this anti-estrogen medication, and we usually combine them with the CDK4/6 inhibitors like ribociclib, Verzenio, or Ibrance. So you'll see that Verzenio is now moving to the earlier stage, like with high-risk patients that I mentioned previously. And in addition to, again, choosing between tamoxifen and these aromatase inhibitors in combination with the CDK4/6 inhibitors, we can use 2 additional medication in this setting. These medicines we do not use for early breast cancer. We don't use for prevention for breast cancer. And one of them is called fulvestrant. That's an injection. It's usually given every 4 weeks. And it's approved in postmenopausal patients with stage 4 breast cancer. And it can be used as monotherapy. It can be used in a combination with one of the targeted medicines. And then the second medicine is actually a pill that was just recently approved in January this year. And it's used for patients who have estrogen receptor positive breast cancer who had a specific mutation called ESR1 mutation. So I think this is where I will end my presentation. See if there's any questions. Yes.
Side effects.
Side effects.
Of the letrozole. My hair is just. But I don't have any other symptoms, joint pain, nothing else.
Yeah.
So I'm kind of afraid to change to something else. And I was reading about that Nutrafol or whatever it's called, that vitamin, but then I heard biotin isn't that great for you if you're not low. So what do you do?
Right, so, and so that's one of this, side effects so that's a tough one, because we talk about biotin, we talk about sometimes the Rogaine too. But there's not a lot that we can do. We can try the switch. So usually I try biotin, we talk about Rogaine, and then we kind of consider the switch. Will the switch work? Like switching to an anastrozole or exemestane? It's hard to know if we don't try.
Because they're all gonna do the same thing as like putting you in menopause anyway.
Well, right, so first you are in menopause already.
Right,
if you're on
right,
these medications.
Right.
But they're going to decrease the level of estrogen in your body. Sometimes, I think they're all generic medicines. So I always think, maybe like there are some other fillers or something else that they put in the medication. So is it possible that maybe switching from one medicine to the other? But in my practice, I have to tell you, I had some luck with, for example, sometimes switching from letrozole to exemestane for joint pain, or other way around, like a switch more for joint pain. For the hair loss, that's the tough. And as you mentioned, most of the patients, they're saying, I do well, I don't have other issues, so I don't have anything else to add.
Okay, one other, can you get dry eye?
So with tamoxifen, there is slightly increased risk of cancer. Aromatase inhibitors, there is some reports of potentially some eye issues, but I have to tell you, these are usually case reports, and it's not that prevalent. The dry eyes I see more in women who are on chemotherapy, because the chemotherapy can cause dry eyes, and then your body tries to compensate, so you actually develop your eyes are runny, and they are runny because they're actually dry. So then we advise patients to take some eye drops, and then that usually helps. So I've seen more with chemotherapy than necessarily with the anti-estrogen medication.
Thank you.
I have two questions from our virtual audience. The first one is, any more info to share on the breast cancer index test regarding 5 years versus 10 years of tamoxifen? Curious what your thoughts are.
The breast cancer, right? So the breast cancer index is a test where we basically request the test, and we do a testing on the tissue that was initially removed from your body. So this is, at the time of diagnosis of breast cancer. And we usually, do that after women have been on the medicine for at least 5 years. The breast cancer index can be used in women who had lymph node negative disease, or 1, 2, up to 3 positive nodes. I mean, multiple positive nodes, I would be leaning towards extending the anti-estrogen therapy for 10 years. But sometimes if there is like tumor that was 1.5 or 2 centimeter in size, lymph node negative disease, after 5 years, the patients are really, that they would like to stop the medication. Then sometimes we send this test, and the test basically comes back with, it takes around, like, I think 4 weeks for the results to come back. And it's most of the time it's covered by insurance nowadays, which is a good thing. And come back with kind of two informations. The first one is that will I benefit from extending anti-estrogen therapy from 5 to 10 years? And that is usually yes or no answer. And then the second one is that what is the chance of this cancer coming back between year 5 and 10? And then they have kind of a lower risk, high risk, the stratification. So where I use this breast cancer index is that, you know, if women had smaller tumors and, especially if they have more problems with anti-estrogen therapy and they would like to stop, they have some stiffness in the joints, more problems with the bone loss. And then sometimes we send the test and we wait for the results of the test just to be reassured that it's okay to stop the medicine. You know, in some cases, we think that extending the anti-estrogen therapy after 5 years, between years 5 and 10, that this benefit that we've seen in the studies may be actually by protecting women from new breast cancer. So that's another thing, just, you know, one point of that test. But for women who had bigger tumors, especially multiple lymph node positive, I would be in favor of extending the anti-estrogen medication after 10 years.
And I have one more online. How long can you use Ibrance?
Well, so that's a good question. So first, you know, Ibrance is one of these new CDK4/6 inhibitors. Let me see. Okay, and Ibrance is actually used for women who have a stage 4 breast cancer. And we can use, there is 3 of these CDK4/6 inhibitor, Ibrance, there is abemaciclib, Verzenio, and ribociclib. So we don't use Ibrance for women who were diagnosed with early stage breast cancer. We use Ibrance for patients who were diagnosed with stage 4 breast cancer. And the goal, and we usually combine that with anti-estrogen therapy. And the goal of that treatment is to control the disease. So women could be on this medicine as long as the medicine is controlling the cancer, and or they're able to tolerate the medication. So, you know, so we are talking, as I said, you know, we usually do in these patients, who have stage 4 disease, we do scans every 3 months, make sure that the disease is stable, there's no other issues. So it is kind of ongoing. But if we use this, we have been starting to use CDK4/6 inhibitor in the setting for early stage breast cancer after surgery. So far, Ibrance, so, you know, Ibrance, I'm not expecting we'll be using Ibrance, but we do have abemaciclib, Verzenio, that has been approved, and we use it for 2 years. And then the third medicine, ribociclib, there was a study that's actually ongoing, and I do expect that might be approved for the setting too.
Thank you. Any other questions this evening? Anybody? No? All right, wonderful. All right, great. Well, thank you so much. I appreciate your time. I appreciate you coming out. For my virtual audience, this will be on YouTube tomorrow. Be on YouTube for your reference tomorrow if you'd like it. So with that, I'll just conclude everything. We'll say goodbye to our team's meeting here, and I hope you all have a wonderful evening.